All right, let's jump right in. Today, we're doing a deep dive on a pathogen that is seriously changing the rules of a classic disease, Corynebacterium ulcerans. Just so you know, everything we're about to cover comes from a comprehensive Gemini deep search. If you want to check out the primary literature for yourself, and I encourage you to, the full list of citations is in our notebook document, which is linked right down in the description.
Okay, let's just pause on that for a second. Read that again. This statement completely flips the script on how we've been taught to think about diphtheria. It signals this massive shift in the epidemiology of a disease we thought we had figured out, and that's exactly what we're going to unpack today.
So how did we get here? This first section is all about setting the stage, really establishing the problem, the changing face of diphtheria in countries with high vaccination rates, all driven by the rise of a zoonotic pathogen.
Here's the deal. The success of our vaccination programs against Corynebacterium diphtheria has been just incredible, but it's created an ecological niche. With human-to-human transmission of classic diphtheria basically gone, Corynebacterium ulcerans has just stepped right in. The primary reservoir isn't other people anymore, it's our pets. We're talking dogs and cats. And listen, this is not just a theory. Whole genome sequencing has given us definitive proof showing genetically identical isolates in sick owners and their beloved pets.
So what makes this bug so dangerous? Well, it all comes down to the diphtheria toxin. The bacterium isn't really a problem until it picks up the tox gene. And here's the crucial part. The toxin from Corynebacterium ulcerans is nearly identical to the one from Corynebacterium diphtheria. What does that mean for the clinician? It means the disease is completely indistinguishable at the bedside. You get the same dangerous pseudomembranes and the same risk of terrifying complications like myocarditis and nerve damage.
All right, let's head over to the bench and see how this all creates some very specific diagnostic challenges that every single clinical microbiologist needs to be on top of. Differentiating the members of the diphtheria complex is absolutely critical.
So here we've got the classic clues we're all trained to look for. Under the scope, you're going to see those characteristic gram-positive, club-shaped rods, sometimes in those Chinese letter formations. On a plate, you'll see small grayish colonies on blood agar, often with a little beta hemolysis. And of course, on Tinsdale agar, it reduces tellurite, giving you those signature black colonies with the brown halo. These are all vital signs for sure, but they only get you to the level of the diphtheriae complex. They don't give you a definitive species ID.
So to get to that species-level ID, you gotta turn to biochemistry. And as you can see here, there are some really clear differentiators. The star of the show, really, is the urease test. Corynebacterium ulcerans is positive, Corynebacterium diphtheria is negative. It's a powerful, fast tool for a presumptive ID. Same story for the reverse camp test, which is also positive for Corynebacterium ulcerans. These simple tests are your best friends here.
Now, let's talk molecular diagnostics, because this is a massive potential pitfall. The tox gene in Corynebacterium ulcerans isn't a perfect match to the one in Corynebacterium diphtheria. This quote is a critical warning. If your lab is still running an older PCR assay that was only designed for Corynebacterium diphtheria, you are at serious risk of completely missing Corynebacterium ulcerans and getting a dangerous false negative result. So the modern workflow has to be way more robust. Step 1, you screen with a modern, validated, multiplex PCR. It's got to target the conserved regions of the toxogene to avoid those false negatives, and ideally it'll have a species-specific target like RPOB. But remember, PCR only tells you if the gene is there. So step 2, you have to culture the organism. And then step 3, you must confirm that the gene is actually producing active toxin. For that, we turn to the ELIC test, the gold standard, which separates the truly dangerous strains from those that just carry the gene without expressing it.
Okay, so we found it, we've identified it, now what? How do we treat it? This next section is all about the latest standardized guidance, and it includes a huge breakthrough from EUCAST, the European Committee on Antimicrobial Susceptibility Testing.
First things first, the core principles. An infection with a toxigenic strain is a straight-up medical emergency. You do not wait for the lab to confirm. The single most important thing you can do is give diphtheria antitoxin, or DAT, to neutralize the toxin. The earlier, the better. At the same time, you hit it with antibiotics to kill the bacteria and stop them from making any more toxin. And of course, supportive care is absolutely vital.
Looking at the adult antibiotic guidelines, you start to see some interesting differences. The Dutch guidelines, for example, really favor clarithromycin. But if you look at the broader international guidelines from the WHO and the CDC, they've historically leaned on erythromycin or penicillin. Both approaches, though, stick to that standard 14-day course of therapy.
And for kids, the principles are exactly the same, but dosing, of course, is strictly weight-based. You can see from these examples, different health authorities have their own specific guidance. The Belgian guidelines point to clarithromycin, the WHO recommends erythromycin or penicillin, and for prophylaxis, you can see New South Wales Health in Australia has a weight-based azithromycin regimen.
Now, for years, when it came to susceptibility testing for this organism, labs were kind of in a tough spot. There were no official breakpoints, so you basically had to guess or extrapolate from other species, which is never a great feeling. But in 2023, that all changed. And here it is. This is the solution. EUCAST published the first ever evidence-based clinical breakpoints for Corynebacterium ulcerans. This is a massive step forward. It allows for standardized, reliable reporting. It gives us clear guidance, for instance, showing that for benzyl penicillin, isolates are in the I category, susceptible increased exposure, which tells clinicians that high-dose therapy is what's needed. It also officially codifies what we already knew, like the fact that this bug is intrinsically resistant to clindamycin.
Okay, let's move to the final piece of this puzzle. How do we prevent it from spreading? For a zoonotic pathogen like this one, it requires a totally different mindset. It's all about applying what we call a One Health framework.
Inside the hospital itself, the infection prevention and control measures are pretty much what you'd expect. You isolate the patient immediately. If it's respiratory disease, you use droplet precautions. If it's cutaneous, you use contact precautions. And you keep those measures going until you've proven the patient is clear with 2 sets of negative cultures after they finish treatment.
But here, this is where the real paradigm shift happens. When it comes to managing contacts, the focus completely pivots. For human contacts, the action is minimal. You're not doing widespread tracing and prophylaxis because human-to-human spread isn't really the issue. The real action is with the animal contacts. This is the cornerstone of the public health response, finding the source, which is almost always a pet, and then working with veterinarians to test and treat that animal to break the chain of transmission. And this is what brings it all together under the One Health approach. Let me be clear. This isn't just some academic buzzword. It is a practical necessity. You simply cannot effectively control Corynebacterium ulcerans without seamless collaboration between human, public health, clinicians, microbiologists, and veterinarians. Everyone has to work together because the health of people and animals are completely intertwined here.
So after all that, what's the bottom line? What does this all really mean for the practicing microbiologist and the clinician on the front lines?
Let's boil this all down. First, the epidemiology is different now. When you think diphtheria, you have to think pets. Second, go back to your lab and verify your molecular assays. You have to make sure they can reliably detect Corynebacterium ulcerans. Third, the ELIC test is still the gold standard for proving toxin production. Fourth, start using the new EUCAST breakpoints for real evidence-based reporting. And finally, that One Health response. It's not just a nice idea, it's a practical must-do. And that really leaves us with this big forward-looking question. This pathogen isn't going anywhere. It is successfully moving into the space that vaccination cleared for it. So the challenge now isn't just microbiological or clinical, it's organizational. Is our system of collaboration between human and animal health truly ready for this?
We hope this explainer on Corynebacterium ulcerans was valuable for you. If it was, please subscribe to the channel for more deep dives like this one. And we would genuinely love to hear from you. Let us know your thoughts on these guidelines or your own experiences in the comments below. We read every single one. Thanks for watching.